This is an instruction video supplementary to the article entitled Real-Time Surgical Margin Assessment Using ICG-fluorescence During Laparoscopic and Robot-Assisted Resections of Colorectal Liver Metastases. In this study, we use indocyanine green, or ICG, as a near-infrared fluorescent contrast agent to guide clinicians during minimally invasive resections of colorectal liver metastases. 24 hours after intravenous injections, ICG accumulates inside immature hepatocytes surrounding the metastasis, creating a specific fluorescent rim as shown in these pictures on the right and the 3D liver model on the left. Although ICG is currently mainly used to identify additional lesions during surgery using this rim, we hypothesize that the surgical removal of the entire fluorescent rim with the metastasis included results in a tumor-negative resection margin as shown in figure B and C. As one can appreciate in the cross-sectional image C, ICG effectively highlights the tumor margin surrounding the metastasis instead of the tumor itself. In our workflow, we use this fluorescent rim to predict the tumor margin in vivo. For example, in the top figure, no fluorescent signal is present in the resected parenchyma, indicating a tumor-negative resection. In the middle image, a fluorescent signal is present in the parenchymal side of the specimen produced by a protruding fluorescent rim, indicating a potential tumor-positive margin. In the bottom image, a residual rim in the wound bed and a protruding fluorescent rim at the parenchymal side of the resection specimen is present. In our experience, a protruding rim is found to be the most accurate predictor of a tumor-positive margin. We have implemented ICG fluorescent-guided resections into daily practice using a 5-step approach, as can be appreciated in this flow diagram. Now let us look at this 5-step approach using 2 surgical cases as an example. First, the surgeon identifies the lesion using both preoperative scans and near-infrared imaging. The fluorescent rim can be clearly appreciated here. Next, using a laparoscopic or robotic compatible ultrasound probe, the rim is correlated to the tumor's location and size below the liver surface. In the third step, the lesion is demarcated using, in this case, a permanent Caltri hook. If necessary, the ultrasound probe can be used to confirm the location of the planned resection line with the tumor's location. Thereafter, the surgeon can start the resection guided by the fluorescent rim. During the actual resection, an inspection of the parenchyma for fluorescent signal is performed routinely. In this case, some fluorescent background signal is observed, but no protruding rim. The background signal is produced by low concentrations of ICG still present in the biliary tract. A difference between the fluorescent signal at the top produced by the rim and the parenchyma at the bottom is clearly present. After finalizing the resection, the wound bed and specimen are both inspected for fluorescent signal. In this stage, it is important to maintain an overview of the wound bed and the specimen. No protruding rim or residual rim is found in this case. In the second case, again, a clear rim feature can be found surrounding the lesion. However, during the orientation phase, the surgeon suspects a protruding fluorescent rim indicating a potential tumor-positive margin. After finalizing the resection, the protruding rim can still be seen when near-infrared imaging is performed in an overview. In this case, the surgeon can decide to increase the tumor margin by performing an additional resection. Therefore, we advocate that for optimal accuracy, the clinician should maintain an overview distance when using near-infrared imaging to assess the tumor margin to minimize autofluorescence caused by reflection of the liver surface. Also, patients with impaired liver function due to, for instance, neoadjuvant treatment might require a 48 to 72 hour window between ICG infusion and imaging. When using ICG as a contrast agent, false positive lesions might occur. In most of these cases, very small and bright fluorescent spots on the liver surface are identified, caused by hamartomas or smaller hemangiomas. In contrast to these lesions, colorectal liver metastases present with a specific fluorescent rim. Last and most importantly, the accuracy of near-infrared imaging, regardless of the contrast agent or camera system, is dependent on the clinician's experience using fluorescent imaging. Although the efficacy of this technique needs to be further studied in a larger cohort, our data showed promising results. A prospective trial studying the effect of this technique on the surgical tumor margin is already including patients. Thank you for watching this instructional video. For further inquiries, please contact the corresponding author listed below.